الرحيم. النهارده ان شاء الله هنتكلم على convalescent plasma in severe COVID-19 patient. دكتورة أمنة أحمد، ICU تيودور بالهرس. Most of coronaviruses are pathogenic to humans, but they produce mild symptoms or asymptomatic infections. However, in the last 2 decades, 2 lethal viruses have emerged within this family: the SARS and the MERS. Last December, a new virus called COVID-19 associated with severe pneumonia was detected in Wuhan, China. Currently, treatment of COVID-19 is challenging. Classical and historical interventions have re-emerged as options for the control of disease because of lack of clinical evidence. Convalescent plasma had been used as a therapy in previous corona outbreaks. A few observational studies were conducted during the very SARS epidemic. These reported improvement in patients with no evidence of severe complications. However, these studies were largely case reports, not the most reliable type of evidence. Researchers hope that convalescent plasma can be given to people with severe COVID-19 to boost their ability to fight the virus. It also might help keep people who are moderately ill from becoming more ill with more complications. Although promising, convalescent plasma hasn't yet been shown to be safe and effective as a treatment for COVID-19. Therefore, it is important to study the safety and efficacy of COVID-19 convalescent plasma in clinical trials. Convalescent plasma, also called immune plasma or hyperimmune plasma, is obtained from individuals who have recovered from an infection and have generated an immune response against the infecting pathogen. The key component of plasma for treating infections is antibodies. Antibodies are proteins that are highly specific for the infection a person has previously encountered. They are produced in vast quantity by beta cells of our immune system in order to bind to the invading virus and then target it for destruction. The concept of vaccination relies on stimulating antibody. In contrast, using convalescent plasma involves the transfer of antibody from donor who have already mounted an immune response, thus giving immediate but transient protection to the recipient. Several convalescent blood products such as intravenous immunoglobulin and polyclonal or monoclonal antibodies have been developed to treat infectious conditions. However, in situations of emergency, they are difficult and expensive to produce immunoglobulin and may not yield an appropriate infectious control. Thus, the use of convalescent plasma has been widely used in different outbreaks as the first therapeutic option given the lack of effective medication or vaccines, and often as last chance or experimental treatment. The vast majority of patients who recover from COVID-19 illness develop some level of circulating neutralizing antibodies to various COVID-19 proteins. This occurs 2 to 3 weeks following infection, detectable by ELISA or other quantitative assay. Convalescent plasma includes a variety of blood-derived component. Plasma contains a mixture of inorganic salts, organic compounds, water, and more than 1,000 proteins. In addition to neutralizing antibodies, other proteins such as anti-inflammatory cytokines, clotting factors, natural antibodies, defensin, pentrexin, and other undefined proteins are obtained from donors. Convalescent plasma can provide passive immunity in the form of neutralizing antibodies and or possibly other immune mediators directed against the infectious pathogen. Antibodies that bind to the virus decrease viral entry into cells and enhance viral clearance via antibody-dependent phagocytosis or antibody-dependent cellular toxicity. Convalescent plasma may provide immunomodulation via amelioration of severe inflammatory response, which is the case of COVID-19, in which an overactivation of the immune system may come with systemic hyperinflammation or cytokine storm. Cytokine storm caused by interleukin 1 beta, interleukin 2, 6, 17, 8, and tumor necrosis factor alpha. This inflammatory reaction may perpetuate pulmonary damage and reduction of pulmonary capacity. Last March, the FDA approved emergency use of convalescent plasma in patients with severe or life-threatening coronavirus infection. Severe disease is defined as one of the following: shortness of breath, respiratory frequency 30 per minute or more, blood oxygen saturation 93% or less, partial pressure of arterial oxygen to fraction of inspired oxygen ratio less than 300, lung infiltrate more than 50% within 24 to 84 hours. Life-threatening disease is defined as one of or more of the following: respiratory failure, septic shock, or multiple organ dysfunction or failure. Last April, the FDA expanded the protocol to enable a wide range of adults to be treated with convalescent plasma by including those at risk of severe disease as well as patients with severe disease. The age of the donor ranged from 18 to 55 years, suitable for blood donation. Initially diagnosed with COVID-19 by nasopharyngeal swab at time of illness, or a positive serologic test for COVID-19 antibodies after recovery, with 2 negative PCR test results from nasopharyngeal swab at least 24 hours apart before hospital discharge, and must be discharged for more than 2 weeks from the hospital with no persisting COVID-19 symptoms. COVID-19 neutralizing antibody titer if available. Donors from endemic areas for tropical disease as malaria should be excluded. The FDA doesn't recommend testing donated blood for COVID-19 as respiratory viruses aren't transmitted by transfusion. Convalescent plasma collection based on routine plasma collection procedures via plasmapheresis to collect a large volume of plasma. A single donor collection can be used to treat 2 to 3 recipients. Plasma products were prepared as fresh frozen plasma. The individuals most likely to produce high antibody titer, the sickest people, and patients who generated the most robust immune response. A study that evaluated immune response in 126 COVID-19 convalescent plasma donors at a median of 43 days after an initial positive test for infection found that males are had higher antibody level than females. Older individuals had higher levels than younger individuals. Those who were hospitalized had higher levels than outpatients, and there was a positive correlation with C-reactive protein levels. In COVID-19, the patient received convalescent plasma between D6 and D50 after the onset of symptoms or admission to hospital. Convalescent plasma is more likely to be effective if given early in the course of disease. Once the infection has progressed to the point that organ damage or other consequences of massive inflammation have occurred, it is uncertain to what extent convalescent plasma provides benefit, as it isn't expected to treat these complications. It is important to bear in mind that there are several potential risks with receiving plasma from another person. First, artificially supplying antibody might make an infection worse, a rare phenomenon called antibody-dependent enhancement. Antibodies that bind to a virus may be taken up by cells expressing antibody receptors. This could enable the virus to enter cells that are aren't normally susceptible to infection, which may increase the number of new viral particles made. A second risk is that preformed antibodies may block the body's own immune response from responding adequately. This occurs with maternal antibodies that pass naturally from mother to offspring, can prevent the infant from responding correctly to vaccination. This is why most childhood vaccines are started after 8 weeks of age. The risk of transmitting blood-borne infection. Fortunately, this risk can be minimized by screening the donor for infections. Another limitation is that the elderly population who is weak the heart or lung, those high risk from COVID-19, may not tolerate receiving such a large volume of plasma. This can lead to a transfusion-associated circulatory overload. Mild side effects include developing fever or allergic reaction such as a rash and an itchy sensation. COVID-19 reports have shown that administration of convalescent plasma is safe and it wasn't associated with major adverse events. Blood typing of convalescent plasma must be compatible with the patient blood type. In addition, should be cross-matched with the patient red blood cells to ensure compatibility. Convalescent plasma isn't different from standard plasma transfusion. Some institutions or clinicians routinely pre-medicate with antihistaminic. However, patients with a history of certain immunologic reaction may benefit from or require pre-medication. It takes about 1 to 2 hours to complete the procedure. Because this investigational therapy hasn't yet been tested, the patient should be closely monitored after the convalescent plasma transfusion. The optimal dose of convalescent plasma is unknown. A Chinese pilot study showed a minimal use of a single dose of 200 ml of convalescent plasma. Another study reported a maximum of 2,400 ml of convalescent plasma administered to a 73-year-old male patient. Observational studies have generally used 1 or 2 units. Another study used 4 to 13 ml per kg of recipient body weight, approximately 10 ml for the first 15 minutes, which was then increased to approximately 100 per hour with close monitoring. Adjustment in the infusion rate were allowed based on the patient risk for volume overload and tolerance. Due to variability of convalescent plasma doses in reports, the optimal dose of convalescent plasma treatment for COVID-19 couldn't be determined. Current recommendation 3 ml per kg per dose in 2 days. This strategy facilitates the distribution of plasma unit and provide a standard option of delivery in public health strategies. Many studies are using plasma from non-infected patients as the placebo arm of the trial to ensure that any benefit identified are indeed specific for COVID-19 antibodies. The antibodies remain effective for several weeks to a few months. For most patients, this duration would provide sufficient viral neutralization until the patient recovers or generates an endogenous immune response to the virus. Thus, for therapeutic use in non-immunocompromised individuals, a single dose is likely to be sufficient in most patients. However, repeated doses in individuals who appeared to have benefit but continue to have evidence of active disease. Some clinical trials, particularly of critically ill patients, allow for repeated dosing. There are no established guidelines to specify what clinical and laboratory monitoring is indicated in recipient of convalescent plasma. Clinical and lab outcomes are being evaluated in clinical trials, including recipient antibody titer in selected studies. Studies on convalescent plasma. The first randomized trial of convalescent plasma included 103 patients with severe or life-threatening COVID-19. The transfusion of plasma was done about a median of 30 days from infection. The immunoglobulin titer was at least 1 to 640. The plasma dose was 4 to 13 ml per kg of recipient body weight. The outcome showed lower 28-day mortality, greater likelihood of hospital discharge by 28 days, faster improvement, and greater likelihood of improvement. But better outcome didn't reach statistical significance. Tolerability, 1 minor transfusion reaction, chill and rash, and 1 possible reaction, dyspnea, both of which resolved with treatment. An observational study involving 46 individuals with COVID-19 who were treated with convalescent plasma reported relatively low mortality. 30 patients were on CPAP, 7 patients were intubated, The plasma administration was 7 days after infection. The dose 1 or 2 units. The titer of immunoglobulin was at least 1 to 160 or 1 to 320. The outcome at 7 days, the overall mortality was less than the mortality in a matched cohort of 23 individuals. Adverse events 5, with 1 transfusion stopped for possible allergic or anaphylactic reaction. An observational study involving 39 individuals with COVID-19 found improved outcome with convalescent plasma, including better survival in a subset of patients. The titer of immunoglobulin was at least 1 to 320. The dose was 2 units of plasma. The outcome, patients who received convalescent plasma had a greater likelihood of stable or improved oxygen requirement at 14 days. In an adjusted analysis, convalescent plasma was associated with a survival benefit in a non-intubated patient. Another observational study involving 21 individuals in ICU compared outcome in 6 who received the convalescent plasma based on availability and blood type, and 15 who didn't. Outcome, reduced viral shedding was observed in those treated with convalescent plasma. However, survival was poor overall, with only a single survivor in each group. The conclusion, convalescent plasma is a safe and potentially effective strategy for treatment of emerging and re-emerging pathogens, especially without proved antiviral agents or vaccines. The vast majority of patients who recover from COVID-19 illness develop some level of circulating neutralizing antibodies to various COVID-19 proteins 2 to 3 weeks following infection. Researchers hope that convalescent plasma can be given to people with severe COVID-19 to boost their ability to fight the virus. Limited evidence suggests improved outcomes in hospitalized individuals with severe COVID-19 if convalescent plasma is given early in the disease course, although additional trials are needed to determine the optimal recipient characteristic at the timing. Most studies lacked standardization and procedure control in donor selection and the type or level of antibodies in convalescent plasma. The guidance on convalescent plasma issued by World Health Organization highlighted the importance of standardized process and the lab testing based quality control of convalescent plasma unit, the selection of clinical indications, as well as program deployment to recruit adequate numbers of donors. There are challenges to maintain a supply of convalescent plasma after an outbreak starts to resolve, as the number of recently affected, highly motivated individuals may decline, and the infrastructure and the resources for collecting and or storing convalescent plasma may no longer be present. Approaches for maintaining the supply for future outbreaks or a second wave of an outbreak might include banking units for further use, immunizing selected individuals to generate a high titer unit, immunizing animals as is done with reps, immune globulin from horses, generating immortalized lymphocytes to produce monoclonal or polyclonal antibodies. Thank you.